All right, I'm Dr. Ebony, again here at the Indigo Hotel in Los Angeles, California, and I am with Mr. Mike Griffith. He's with Advanced Oxygen Therapy Incorporated, and we are going to talk about how to heal a diabetic foot wound. This is what we see a lot of in podiatry, and this is a great way for in-home therapy. So without further ado, I'm going to let you describe your company and describe what your therapy provides.
Absolutely. So we're Advanced Oxygen Therapy, and we provide an adjunctive modality, which is a multimodality, using cyclical pressure topical oxygen. So here is when podiatrists or physicians treating the patient with a non-healing diabetic foot ulcer, they can order this in addition. We set the patients up at home, they do the therapy at home, and it allows us to deliver oxygen under cyclical pressure, which combines non-contact compression to reduce any edema that might be present, and it's needed humidity, and all of this helps the wounds heal.
Wonderful. Yeah. And just for clarification, sometimes the diabetic wounds, they go to wound care.
Yes.
And in wound care, they are provided with hyperbaric oxygen chambers.
Yes.
Is this product in addition to or in lieu of?
In lieu of.
Okay.
I mean, full body hyperbaric changes where the patient's whole body goes in the chamber.
Right.
Obviously have proven to be effective, certainly on diabetic foot ulcers, but there are many contraindications and risks,
right,
and many patients just don't qualify for various reasons.
Right.
So they're generally, because of that, used as a sort of end stage when they've tried everything else. Mm-hmm. Ours is something where you can use a lot earlier. So if you have an ulcer that's just not healing with all the care that you're doing and stalled and just not progressing and maybe going in the wrong direction,
right,
then ours is an option that you can use at that stage. You order it, you continue to do good standard wound care, good debridement, appropriate offloading if it's a diabetic foot ulcer or compression, and you order this in addition. And we set up the patients, they do the therapy at home, they come back in for their regular wound clinic visits, and hopefully the wound's progressing and you continue until healing.
And you do this every day, 5 times a day?
Our recommendation protocol is 5 times a week, 90 minutes per session, and that's what our studies have shown is effective. But there's really no contraindication to do it more often, but that's sort of the minimum protocol.
Right.
Yeah.
And a lot of times with diabetic foot ulcers, people apply wound vacs.
Yes.
Can this be in addition with the wound vac intact?
The only thing that you can't do is you can't have dressings or things like wound vac that create a barrier for the oxygen to get to the actual wound tissue, because it has to diffuse in. So negative pressure or wound vacs really can't be done at the same time. It could be done serially. Mm-hmm. But what we found is, if we looked at the evidence for our studies, is we are particularly effective in chronic wounds, diabetic and venous ulcers that are stalled, whereas negative pressure, although it's used in diabetic ulcers, is usually more exudative infected wounds.
Right.
So, it's sort of horses for courses and picking the right tool at the right time. So, so what we find is, if you have a wound that's stalled, we believe we should probably be a frontline therapy. And in many cases, if you have patients with gas permeable dressings, which most dressings are, they leave the dressings in place and they do the therapy at home just over those dressings.
Right. So just as a timeline, if someone has an infected wound, you can take them to surgery, debride the wound, apply a wound vac, and maybe a month later start this, or maybe even right away, don't even apply the wound vac.
I think you have both options. I think the reality is as a clinician, it's another tool in your tool belt to decide when to use.
Right.
We would because the benefit of oxygen and wound healing, the first thing it does is help kill directly anaerobic bacteria, but it also provides fuel for the neutrophils to take on other bacterial burden. So we see a significant upregulation in leukocyte function and the body's immune system, and because of that, then obviously it's very effective on infected wounds. So clearly using it earlier is probably better. But if you have a lot of bioburden and you want to use the vac to remove that for a while, there's nothing wrong with that either.
I completely agree with you. Like, not everybody is a great candidate for the hyperbaric oxygen chamber. And so this is like a really amazing tool that you have, especially because it can be done in the comfort of your own home, right?
And that's the real benefit. I think one of the biggest issues with full body hyperbaric are the risks and contraindications, but also patients have to go 4 or 5 times to a full body chamber center, for 2-3 hours. It's very difficult for many. And many of these patients are comorbid with lots of other diseases.
Right.
It's not easy for them to deal with that. So what we see is, certainly if a patient doesn't qualify or this isn't a candidate for full body hyperbaric, this is a good alternative. But unlike full body hyperbaric, where it's used later in the phase when nothing else has worked, because it's really only covered at those end stage wounds, our therapy can be used much earlier in the process. And the sooner you use it, if you take it on the wound that's stage 1, stage 2, University of Texas ulcer, the sooner you use it, we find the sooner the wounds heal. And what's very exciting is we've not only seen from real world experience, but from our latest multi-center, double-blinded, placebo-controlled study that's published in Diabetes Care, we showed that we were not only 6 times more effective at healing at 12 weeks, which is the normal measure, but because the way we heal with oxygen, we lay down better quality collagen and we have better vasculature, angiogenesis feeding it, that we followed these patients over 12 months and had a 6-fold reduction in reoccurrence.
Wow.
Which to me is because clearly with oxygen you can heal the tissue with better quality collagen and it's better perfused. And these to me are the exciting benefits, not just the short-term but the long-term benefits, which ultimately both to the patient's quality of life but also to the payers, to the cost of care, is beneficial all around.
That is beneficial for the doctor, for the patient, for everyone involved.
Exactly. And what I like about it, as a physician, you come to your practice, you have tools that you use that work. We're not asking you to change something that you use. This is adjunctive at home. So what we ask is order this additionally, and our job is to make sure the patients are compliant. Because if they don't use the therapy, it doesn't work. But we find we get very good compliance because it's very easy for them to use. They're doing it whilst they're sitting there watching TV like they would be probably doing anyhow. And what we find is that the patients take more ownership in their wound care because they see progress quite quickly. And that's the worst thing, as I'm sure you see, patients with diabetic foot ulcers or venous ulcers, they lose hope and they get depressed. And if they finally start seeing progress on something where they've been told maybe it's not going to heal, maybe they're going to have an amputation, and suddenly they see it improving, and they get very motivated. And we find if they're able to, they use it, and if they use it, they get outcomes.
Absolutely.